Just to thank Anne-Marie, I don't know if you realise how lucky you are to have her as a lead advocate. I've known her for a long time, and I really am grateful to be asked to talk today. So I'm just a brief outline of the talk that I'm going to give today is really how common clots are, a bit about the post-thrombotic syndrome, and what it is to like living with VT, and then some questions and answers at the end of it. So unlike CTEPH, I would regard CTEPH as the rare of the rare. It's you all remember Donald Rumsfeld, maybe not your favorite neocon, but he talked about uncommonly uncommon things. And CTEPH falls into that category. But venous thromboembolism, which means clots in the legs that can, but don't always, go to the lungs, is really common. So I've been doing general medicine on call for over 20 years. And when I'm on call, I would expect to have at least 1 or 2, maybe even 3, either DVTs or pulmonary embolism. So this is a really, really common thing. So again, I think the important thing to remember about CTEPH as well is a very small percentage of that group go on to develop it. So we're talking about 1 in 1,000 for clots in the legs or the lungs, but for CTEPH, you're talking about 1% of that 1 in 1,000. So you're into the 6-digit number. So it's just to reassure you, CTEPH is rare. Post-thrombotic syndrome, however, is common. So this is the problem that you develop with your legs after having a DVT, and that's what really today's talk is about. It's extremely burdensome. It has major economic significance and affects patients frequently. And I'm sure there are people in this audience today with this syndrome. Hopefully not too many people with CTEPH. Right. So that's what it looks like at the end point. So when you've had this problem for a long, long time, your legs end up being quite severely affected. It's a painful condition. Initially, you get a lot of swelling, but after a long, long time, that swelling can end up in a lot of scarring. So you can end up with what we call an inverted champagne bottle type leg. So the skin gets very tight around the ankles. Also very discolored. That red, tingy, bluey sort of color is actually the effect of blood, the pigment in blood leaking out into the tissues. We call that stuff hemosiderin. So the risk factors for developing the post-thrombotic syndrome are clots, and the bigger the clot, the higher the risk of developing PTS. Equally, if you have a second clot, the risk of PTS increases 6-fold. The reason the higher up the clot matters is down to first principles. You can think about the venous system as a low pressure system. It's gravity affected, unlike the arterial system, which really isn't affected much by gravity unless you're pulling G-forces in a supersonic jet. But the venous system is affected significantly by gravity. And what prevents PTS developing in people that haven't got a clot or had a clot is the little valves inside the veins that get damaged by DVTs. After that occurs, you can end up with what we call venous hypertension in the legs, and this is very, very common after an acute PE. Having varicose veins is a risk factor. Varicose veins are a marker of already having high pressure in the venous system. So these are the superficial veins, these ropey little, not the spidery tiny ones, but the big ropey ones that you often see behind the knee that can get inflamed, so-called phlebitis. And obesity is another risk factor, as is getting old and having had lots of children. Residual clot, in other words, I think a question was asked early on, is my clot gone? How do I know my clot is gone? What we've learned with post-thrombotic syndrome is that there is a significant proportion of patients that don't properly recanalize. So what do I mean by that? I mean that the blockage that was there has opened a bit, but not completely, and the lining of the vein has become thickened. So this isn't acute clot, it's more organized clot. And what we do know is that if you don't fully recanalize after your initial DVT, which is actually quite common, nearly 3 in 10 patients, you have a higher incidence of developing the post-thrombotic syndrome. So obviously the best way to avoid the post-thrombotic syndrome is not to get a DVT. And if you do get a DVT, which is unfortunate and is quite common, is to get it diagnosed and to get it treated quickly. The longer that clot stays there undiagnosed, the higher likelihood that you're going to end up with long-standing problems with your legs. Getting anticoagulated in a timely manner. Now we're using the DOACs. I'm sure you've all heard of the direct oral anticoagulants, rivaroxaban, apixaban, edoxaban, petrixaban. They are the preferred treatment now, over and above warfarin. Warfarin we only use in very rare situations now, and sometimes heparin. The other somewhat more controversial treatment for an acute clot is removing the clot surgically. So when you take an anticoagulant, what an anticoagulant does is stops new clot forming. It doesn't dissolve the clot. Another misnomer, a lot of patients feel the medication they're taking is dissolving their clot. It's actually not. What it does is stops new clot forming. Your body is full of chemicals that naturally are resolving and absorbing clots all the time. And what taking a DOAC or heparin or warfarin does is just tips the balance of clot formation and clot resolution in the favor of clot resolution to allow your body to do its thing. But what you can also do is manually remove that clot. So sort of similar to the surgery you've just seen, but this is done through interventional radiology where doctors put in a catheter up the leg and literally pull the clot out or put in a lytic medication to dissolve the clot. Now, that procedure is done in a few places in Ireland. It's done in Galway, it's done in a few centres in Dublin. We do it rarely in Limerick. And the reason we rarely do it is because anticoagulation is so good and is often unnecessary. And there are risks associated with mechanical thrombectomy and thrombolysis, and those risks are bleeding. So we try and avoid this. Sometimes we need to do it in people that have had really very large clots, who've got very painful, very swollen legs, who can't walk. The initial argument was that doing this prevented the post-thrombotic syndrome, in other words, manually removing the clot, rather than giving an anticoagulant and waiting for the body to reabsorb the clot itself, would be better at preventing the post-thrombotic syndrome. And in fact, the evidence for that now is that it probably does not. So we reserve this procedure for very, very large clots in people that have a lot of pain, and in particular those that do not respond to anticoagulation. So it rarely is done, but it is done. So what about stockings? Well, the problem with the post-thrombotic syndrome is venous hypertension. And what stockings do is they're like a G-suit. So again, you remember my discussion about test pilots pulling G-forces. The reason test pilots wear G-suits is because when you're pulling a lot of Gs, although it doesn't affect the arterial system, it does affect the venous system. So if you're pulling 4 Gs in a supersonic Eurofighter, what happens is all the blood rushes to your legs, forced by gravity. And of course, if you're blacking out in a supersonic jet at Mach 4, that's bad. So these G-suits that pilots wear sense Gs, and they squeeze the legs of these pilots. And if you get a chance to talk to a pilot flying these supersonic jets, he'll tell you that the G-suits actually become incredibly painful when they're pulling Gs, because their legs, the pilot's legs, are literally being squeezed. That's what stockings do. They provide pressure. Graduated pressure stockings provide more pressure at the ankles and less above the knee, because that's where the pressure is affecting the most. The pressure, courtesy of us all being bipedal upright primates, the pressure is greatest at the ankles when we're walking, and that's why ulcers develop at the ankles. So these compression stockings do work. They are the only treatment for PTS, particularly if you've got venous ulcers. If you've got ulcers, which again occur around the ankles, the lowest part of the leg, really, it's recognized now that 4-layered compression bandaging is the best treatment in terms of healing those ulcers. Now, that's not to say that everyone that develops a DVT should wear stockings, and I'm sure I'm going to get asked questions about this. I know that in my clinic, which I do every Thursday, today we've had to cancel it, that patients are always asking, should I wear stockings? They've had their first DVT, should they wear stockings? And the answer to that is there is no evidence that wearing routine stockings after an acute DVT, so this is distinct from the post-thrombotic syndrome, this is people that have just presented with an acute DVT. There is no evidence, and we do not recommend the wearing of stockings. And in fact, if you look at the evidence overall, there's possibly more harm from these compression stockings than good if they're not fitted properly, because they are tight, they can cause skin breakdown. We have a lot of older people falling over trying to get them on and off every morning. So we do not recommend the routine use after an acute DVT. But we do for PTS, obviously. There are lots of mimics of DVT. Again, this gets back to the importance of making the correct diagnosis, getting a timely assessment from someone who's trained and knows how to assess acute DVT presentations, who know what a Wells score is, who know when it's time to do a special blood test to look for clot turnover. You may have heard the term D-dimer. And equally then to refer for an appropriate ultrasound. And a lot of acutely swollen legs are not DVTs. Baker's cysts, which is like a blowout of the knee joint, is a really common mimic for DVT, and obviously the treatment for that is not anticoagulation. Your legs can swell from blockage of the lymphatics and serious diseases in the pelvis as well, so it's very important you get evaluated and diagnosed correctly. So what are the other treatments of the post-thrombotic syndrome? Another really common question I get asked in my clinic is about exercise, particularly after PE, but also DVT. And remember, DVT and PE are the same illness. We know from studies, particularly long-haul flight studies, that up to 70% of people that think they've just had a DVT have also had PEs. They just don't know. So Katrina mentioned that 70% of people with CTEPH have had a PE, a recognized PE, but that means 30% haven't. So I would argue, and I think everyone believes this, that the 30% are people that have had silent PEs. So PEs happen without you knowing. And I think Katrina said quite correctly, your lungs have evolved to do two things. They've evolved to absorb oxygen, but they've also evolved to provide a filter. They're like a big sponge. All of your blood supply goes through your lungs, 5 liters of it, and your lungs are like a mesh, a fine reticular mesh, and they sift out small clots. So in many ways, what we do know now with CT scanning is that you're having PEs all the time, small, tiny little ones. They're normal, they're physiological, and your body deals with them and your lung deals with them very, very well. But bigger PEs that cause symptoms are really what we're talking about today, and we know that people with DVTs almost certainly, if you look for them, will be having small pulmonary emboli. The treatment is the same. So prevention is obviously the key here. Once you've had a DVT and your legs are swollen, other than compression stockings, what can you do? Well, your veins, again, are a low pressure system and they're within the muscles. So strengthening your muscles after a DVT is very, very important. But strengthening them in a way that tries to avoid the effects of gravity. So don't forget, gravity is what's driving this high pressure in your veins. So the sports that I recommend are sports that minimize the effect of gravity as much as possible. So running and pounding the pavement, asphalt, concrete, is actually quite, you're putting a lot of pressure on your venous system. And in fact, you'll know after you've had a DVT, you find that walking on the pavement, you get this dragging, heavy sensation in your legs. So, it's better than not doing any exercise. But the exercises that I recommend are water-related exercises. So aqua aerobics, swimming, these are great exercises for your lower limbs. They strengthen your muscle pump. You don't get the effects of gravity, and are really very, very helpful. And I would include PE in that group. If you've had a PE, the chances are that clot has come from your legs. And you can develop PTS without even having had an acutely swollen legs, because the clot has probably come from your legs, even though it hasn't caused any pain or swelling. The other little trick I tell all of my patients with DVT, particularly the ones that I think are developing PTS, they're coming back to the clinic, their leg is still swollen, it's painful, is to raise the end of the mattress. So if you stick a pillow at the foot end of your mattress, it'll get squished by the weight of your mattress, but what it'll do is raise the foot end of your mattress by an inch or half an inch. If you're wealthy enough to afford one of those fantastic electronic beds that can whip your feet up just 5 degrees, again, another really good thing to do. And the logic behind that is, if you think about it, you're going to spend roughly 8 hours in bed every 24 hours. And if you can elevate your legs to the level of your heart, what you're doing while you're sleeping is you're taking away that venous pressure. And it's the chronic high levels of pressure. You can't avoid some of that by standing up, but when you're lying down, if you can avoid 8 out of 24 hours where you're taking that pressure away from the venous system, the damage that's caused by that pressure is mitigated. So again, a really nice, easy thing to do. Compression stockings we've talked about. Now there's various types of compression stockings. I initially talked about the 4-layered graduated compression stockings, which we would be using for the severe end of the spectrum. You can also get grade 2 and grade 3. You've heard of these terms from the pharmacy. They can be prescribed. I think that they are useful. The problem with just going to the chemist and buying these stockings without being assessed is if you have arterial disease as well. So these stockings, if you've got bad arterial disease, can also impede arterial circulation. So all I would say is you should be assessed appropriately rather than just buying over-the-counter stockings. Skin softeners, again, very useful. Also anti-inflammatory creams, particularly for that red, angry skin rash you can get with the post-phlebitic syndrome, so like betamivate, hydrocortisone. I think they are safe to use, and you can get a lot of them over the counter, and they're quite good to use. The surgical interventions, I think I'm going to, I think they are controversial and we're talking now about the surgical interventions of the post-thrombotic syndrome. So some of you may have had venous studies looking at the venous supply to your legs because of maybe varicose veins or maybe because of the post-thrombotic syndrome. I think the surgical interventions here are controversial. I think if you're going to get it done, again, as Katrina was saying, get it done by a vascular surgeon that's done 100 or 200 of them. These are not the sort of interventions that should be done by someone who sort of dabbles in this area. The prognosis, unfortunately, because this often goes unrecognized, often the prognosis is quite poor. It affects quality of life, it affects mobility, it affects the ability to exercise. It then becomes a vicious spiral of, I can't exercise, I can't get around, and then you start getting leg ulcers. So really, it is an incredible burden to the system, and I think it's something we do very, very poorly, and something that hopefully will be addressed in the new care program that we're establishing. So prevention, obviously better than any cure. Be aware of the signs and symptoms of acute DVT and pulmonary embolism. See your doctor, get assessed properly, get treated. Anticoagulation, as timely and as early as possible is the way to avoid this syndrome. And I don't know, that's it really. So I'll take any questions.
Visit thrombosis.ie. Spot the signs, save a life.